Hey, good morning everybody. It's been a long time since I've made a new video. I'm gonna just give a quick update on our progress that we've made with the KCCC pilot project. So for those of you who are not aware, a group of us, Landon, who is the lead healthcare provider at KCCC, and the warden and the folks on Oahu who manage the healthcare delivery for DPS, the Department of Public Safety. We've all gotten together and have tried to create a pilot program at KCCC to try to better implement treatment, identification, discharge planning for those inmates who have a history of chemical dependency. And so, we've been working on this now for coming up on 2 years, and we've made some progress. So we're now involved in a study, a nationwide study involving sites from Maine to Hawaii, sponsored by a number of institutions, but mostly from the University of Wisconsin, where we're getting some expert advice and guidance, and so it's been exciting, and it's been an opportunity to really organize and move forward. So now we have a couple patients, I'm going to try to stick with the term patient rather than inmate, who are currently at KCCC that we're trying to implement now not just the naltrexone, but buprenorphine. So one of the inmates is probably going to be there for a while, has been on buprenorphine, and so we're going to try to taper this person down if the person is going to be there for a while, and then ramp back up again and either discharge this person on sublingual buprenorphine or on the sublocade injection. The other individual has been a patient of mine for a long time, has been in and out of KCCC numerous times, and what we're going to try to do is take this individual who is not on buprenorphine right now and start at a low dose, gradually increase that dose up to the dose that's necessary to be on before you can receive the buprenorphine injection, otherwise known as sublocade, and then the day or two prior to release, give the sublocade injection so that that person is blocked from using opioids. The individual is very excited about this, and just wants to try something different, has to try something different. And so hopefully the members of the nursing team and the medical providers, the physicians who are providing care at KCCC, will kind of understand what we're trying to do. Another important development is we have an on-site certified substance abuse counselor who is better able to counsel and identify individuals who would benefit from treatment. And so we're just really making some good progress now, and I hope that within this next 12 to 18 months we can show the other sites that implementing a multifaceted chemical dependency treatment program within a jail is not that difficult. Another important development has been the federal government no longer requires a DEA special license to prescribe buprenorphine. Any licensed physician can prescribe buprenorphine, so that takes away a major barrier both at KCCC and elsewhere. So just a few fine points. You have to be on a minimum of 8 milligrams of buprenorphine for a minimum of 7 days to make sure that the person is stable before you can get the sublocade shot. And so, somebody who's not on buprenorphine at all, if you just start them on 8 milligrams a day, that's probably too much. Many of these people have some underlying opioid tolerance still. So, in my experience as an outpatient, people who've been off buprenorphine for a while they are still pretty tolerant to it. So ramping them up is fairly easy. For those people who were trying to be more careful with, and rather than just having them come in on buprenorphine and just having them go through terrible withdrawal, trying to step them down. As an outpatient, we usually, if people are ready to get off of buprenorphine, we usually reduce the dose by 2 milligrams every 2 weeks down to the 2 milligram size. So that's a quarter of an 8, and then we switch them over to the 2s, and then again go down by a quarter of a tablet. Now 0.5 milligram every 2 weeks until they're taking 0.5 milligram every other day for 2 weeks, and then stop. Now this is a very long taper because we don't want people to be in withdrawal and have symptoms. And so, everybody's wired a little differently. So some people can go a little faster, some people need to go a little slower. But generally speaking, reducing no more often than every 2 weeks allows the brain to kind of catch up and reorganize its receptors for the opioids, and then reducing by no more than 2 milligrams at a time down to 2 milligrams. And because of the way buprenorphine works, the first couple milligrams are very potent, and then as you take more and more buprenorphine, it has less and less of an effect. So once you get to like 3 or 4 8 milligram tablets a day, taking more doesn't seem to have any further effect. Taking 5, 6, or 15 has no further effect. So in that way, it's very safe. It's very difficult to overdose on because there's a strong ceiling effect, but it does kind of make it kind of weird where, if you go from 3 8 milligram tablets a day down to 2, there's hardly any effect to drop from 8 milligrams at a single time. But then to go from like 2 milligrams down to 1 milligram, that 1 milligram dose makes a huge difference by the time you're down to that dose. So it is kind of a strange medicine in that way. It is a non-linear dose response curve where the first couple of milligrams have a dramatic effect, and then way down when you're at 24 milligrams or more, it doesn't seem to have as much of an effect to add 1 or 2 milligrams. So for the nursing staff and the other providers at KCCC, we're making good progress. Identification is still critical. We think that 60 or even 70% of the inmates at KCCC have a history of chemical dependency. At release are at risk for relapse. The one individual that we're tapering off, just a couple days ago, we were talking with him, and from his experience in Arizona, he was like, yeah, just a whole bunch of my friends would be released, would relapse, and then would die. And so, from this person's personal experience, like he knows that, there is a substantial risk of relapse and complications from relapse, including rearrest and, medical complications or relapse, including an overdose death. Those are the things we're trying to accomplish. Theoretically, the overall number of people at KCCC and throughout the state who are incarcerated will go down if we more aggressively identify and treat chemical dependency. And one more note before I sign off, there's a recent study that was very exciting. So far, there really hasn't seemed to have been a substantial impact on meth use from any drug, but a recent study came out looking at naltrexone, also known as Vivitrol shot, which we're already given at KCCC, in combination with bupropion as an antidepressant, also known as Wellbutrin, also used for smoking cessation as Zyban. So it's already been used for stimulant abuse. The combination of those two seemed to substantially reduce relapse rate and improve outcomes for methamphetamine dependent patients. So that's kind of the update on where we are with our pilot program, and we're looking to make some really important further developments and improvement here in the near future. So that's my story. It's cold. It's winter in Hawaii, believe it or not. So I got my fleece on, and have a great one. Thanks.